Bonjour à toutes, bonjour à tous. Nous allons donc
Good morning, everybody. We are going to open this panel discussion, which is entitled Working Together with Gilles Bonnefond, Dominique JAKOVENKO, Pascal ROCHÉ, Marie-Odile and Jean-François. Working together is like a recurring topic. You know, it's like putting the patient at the heart of the health system. Everybody's talking about it, but nobody knows exactly how to implement it. We know what are the blocking points, the hospital-centric spirit of mind, the fact that the shared medical record goes into all directions. But there are local initiatives which are demonstrating that it is possible and it could work very well. But there's one prerequisite, which is that we should start from the field workers and we should trust them, because my conviction is that we should let professionals organize themselves. So how can we make those relationships more smoother, and how can we get inspiration from foreign experiences? These are the topics that we're going to address during that panel discussion. I'm going to start with Mrs. SAILLARD. I cannot see her on the video. Could we have a video from Mrs. SAILLARD? Or we'll start with Mr. JAKOVENKO. He's a nurse, and you are participating in an experience called equilibrium. So patients and doctors with coagulant injections. In fact, the equilibrium experimentation is a major step forward, thanks to the minister and thanks to CNAM. Like Gilles and Olivier said this morning, we are talking about the care and the pluridisciplinary medical social coordination. That experimentation is called Equilibrium, a team of solitary and responsible nurses. We can develop our clinical expertise, and we can try to make the patient more autonomous. So we are part of the cure, but also in the care, because we're here to coach patients to make them autonomous while we keep supervising them. We do coordinate with pharmacists and doctors and the medical social sector, and we enable the patient to recover his life quality. We have so many patients that we have assisted, and we are being remunerated for that. When we feel the patient is ready to do his own subcutaneous injections, he can call us, but he will do it by himself. And we've made many patients autonomous already. We are being remunerated for that. Our clinical expertise is being valued, and we coordinate with the pharmacist. We coordinate our work at homes, and we make assessments with the pharmacist. There are many things that we can do with pharmacists and with doctors, and that experimentation is an example of it. And the 150 people who have benefited from that over the past 7 months, and now we have waiting list of nurses who want to join us, but we're only working in 3 regions. Thank you so much. Congratulations. Pascal ROCHÉ, good morning. You are the CEO of Ramsay Santé, which is the first group of private health. You said that in Sweden, there is an experimentation. The nurse is the first link of the chain, in the chain. In fact, in Sweden, we have 105 primary health facilities. They must, Swedish people must register. There are about 15 professional people. There is one nurse doing the triage at the entrance. And in most cases, the nurse can take care of the patient. If it's not the case, then they will go and see a general practitioner. If the problem must be treated by a specialist, there are a number of specialists. There's also psychologists. We do real-time biology, like the you know, for diabetes patients, we look at the glucose content, and we compare quality. We must share with the 20 Swedish regions. So, in fact, it starts with a nurse. The Swedish person expects to see a doctor, but in most of the cases, the nurse will be able to treat the patient. And then there is coordination with some specialists, with the psychologist. A general practitioner used to see, can see 13 to 14 patients per day. In France, a general practitioner is going to see between 20 to 28 patients per day. So prevention has a meaning. Yes, instead of having doctors taking care of everything, it goes from the patient all the way to the nurse. Thank you very much. Jean-François THEBAUT, you are the vice president of the French Diabetic Federation. It's an old structure. I think it was created in 2009. There are 3,000 patients that are involved. How have you managed to make health professionals work with the diabetes? It is the French Federation of Diabetics. In fact, we include 80 different associations, almost one per département. Taking care of diabetes patients is a collective approach because diabetic patients need to be treated by pharmacists, nutritionists, doctors, diabetologists, and general practitioners. So it is the very nature of the work to work together, and we have initiated the people who were working in the federation. Gérard Romont was the promoter of it. They have decided that it was necessary to assist patients in order to put in place therapeutic assistance and therapeutic education. In 2008, we created a program called Élan Solidaire to train hundreds of volunteers, expert patients that are volunteers and who can participate in a training program in order to participate in educating patients and also assisting patients when there are therapeutic assistance. So this has been in place for the past 11 years. It is being funded by the medical insurance. The patients are trained. Each trained patient can be trained to therapeutic education for 40 hours. We also have training sessions, psychological training, and all patients are being coached and they are being supervised. And it is going to help us to assess the situation. So we have 1,000 expert patients who have been trained over the past 10 years. We have physically assisted 8,500 diabetic patients on the field, thanks to those programs. And as far as therapeutic education is concerned, the regional health agencies are managing them, and the assessment should take place next year. So I don't have any precise figures, but in all therapeutic education programs that are being developed in centers, there will always be expert patients. Thank you very much, Marie-Odile. You are the general manager of the CHR in Metz-Thionville. In fact, in your facility, you've been able to make the administration and doctors work together. And when we prepared for that panel discussion, you said, but sometimes it could be shocking inside the facility, but how have you been able to make that miracle happen? Thank you. Thank you for giving me the floor.
Effectivement, écoutez, bon, déjà, on va dire qu'on a une grande histoire.
We do have a lot of experience of working together for a long time in the Metz-Thionville Hospital Center. It was created in 1977 between Metz and Thionville. And we've been working for a long time on how to regulate the center, the 15 center, and also thanks to the Association of Independent Doctors. For the past 2 years, we have created a CBDS. Sorry, with Marie-Odile, we do apologize, but please avoid the acronyms. Thank you so much.
Entendu. Et puis, nous nous profilons toujours sur ce terreau-là.
And we are still developing from that base. I believe that we are going to be the pilot site of all pilot sites for accessing care. It's going to be developed. It was one of the provisions, and it has been confirmed by the Ségur. So the first answer is that we do have an experience of having major relationships, very good relationships with the town, and it is developing with private doctors. We've seen that the COVID crisis that has hit us in a very violent way, brutal way in the Great East region, and in particular in Alsace and in Moselle. I'd like to say, because I believe that sometimes it tends to be forgotten, people tend to go directly from Alsace to Paris, but in Moselle we had as many fatalities during the first wave than the Haut-Rhin region. And the crisis has helped us to strengthen those links, to put in place a number of mechanisms so we could get some information, we could share some information during the crisis, in a crisis mode, but also now because we are building on what was built at the time. Marie-Odile, we are going to come back to the COVID epidemic, but I'd like to ask Gilles Bonnefond, who is the president of the USPO, which is the Union of Pharmacist Unions. Now, as far as the masks distribution was concerned, how did you manage to satisfy both nurses and doctors at the time? We offered Olivier Véran, that was his first meeting when he became minister. We said, if you want us to help you to protect health professionals that must treat patients, we are prepared to help you. And he did not deny it. He didn't refuse it. And there was a shortage of masks, so we had to manage that. The way the mask distribution was being managed manage was very complicated. We had to retrieve them, count them, to distribute them to the nurses, the doctors, the dentists, and we've been able to distribute masks to people working at homes, caregivers, working with the elderly, and also to the funeral services, the people working for funeral services. So we've done that work under very difficult conditions with shortages. Sometimes there was big misunderstandings from health professionals. They did not understand why we were counting those masks. But in fact, the positive thing is that we've been able to meet with each other because professional people would come to the pharmacy, we would exchange, we would talk about how they were organized. Sometimes nurses that could not have access to other equipments like coats, gloves, visors. We've given visors to professionals to protect themselves. So it was very useful because we've been able to create some bonds and we've helped them to work in a secured way. We have not been remunerated for that. But, you know, it was very efficient and very useful. And in fact, it has had a positive effect because it did show that at one point, by having a complementary action with other professionals, we can help each other in very difficult times. The paradoxical aspect of that COVID epidemic is that beyond the human cost, it has made it possible to better work together. The question I'm going to ask you, concretely speaking, what was the positive aspect of that COVID epidemic in terms of working together? It is true that in the framework of that crisis, what seemed to be impossible one day became possible the next day. We have 133 private hospitals in France, 136 intensive units. So, in fact, we started from the territory. We've worked hand in hand in Lyon, with different hospitals in different areas of France. The seriousness of the crisis was such that we were very ignorant at the beginning. And then we would take care of the elective surgery. At one point, we increased the number of resuscitation beds in 3 days upon the request from the Health Regional Agency. We were working, we did transform many intensive care into resuscitation with provisional approvals given to us by the Health Regional Agency. So we're all here to treat people, and we did focus on patients, and we didn't bother about anything else. And I think that the good point was that we did get to know each other, that whether we are independent doctors, community doctors, we're all doing the same work. You know, it's funny to hear doctors saying that we worked really well together and we were free to do what we wanted. In fact, when you let people do what they have to do, when you trust them, you work better. You know, I was fighting for the past 2 years, so the tandem between the nurse and the doctor would be acknowledged. And during that COVID crisis, where, you know, we had to deal with a situation whereby there were many incoming patients and lack of means and information, doctors with nurses, they came to see us, so we would open a COVID center and we would work together. And in fact, doctors, after discussing for 2 years, they've launched the nurse-doctor tandem. The nurse would do the triage, to welcome the patient, make an assessment, and then the doctor could only focus on the medical examination as such. Now we have to go further than that, and I think the town did open a center for us. We have avoided cross-contaminations, catastrophes, because doctors would not welcome in their practice suspected COVID patients. They would refer them to us, and nurses working in the COVID centers would manage those patients. And like in Metz, we were in close connection with the ALES clinic and hospital. We had common paperwork. Everybody knew each other. Everybody knew they could count on each other. We were avoiding having cross-contaminations between populations, and we would refer them either to the small clinic or to the bigger hospital if it was more serious. And we are all caregivers, and the purpose was to avoid maximum damage. And it means that in an emergency situation, we can organize ourselves at best. Now, Jean-François THEBAUT, what would you like to tell us? I'm not going to tell you. It's your question and not my answer. No, I would like to come back to what was said previously. The fact that you should leave the initiative to doctors, that was true in hospital facilities, but paradoxically, in cities, apart from what we just heard, independent doctors, they've been completely abandoned. They did not feel that they were being supported. And patients have had many difficulties to find a doctor. We did make a survey in the French Federation of Diabetic Patients with the Alliance of Hearts and with the Federation. We've seen that 60% of French people, and it was a survey per region, 200 patients per region, 2,400 patients with all pathologies. 60% had to given up, and 44% had to given up because there was no hospital consultation, no masks. The podologist had to close, for example. But I would like to pay tribute to the pharmacist, which is not so often, because in that survey that we've conducted, which has been published, we've seen that 87% of patients did not have any difficulties and had been to their pharmacist at least once. And the pharmacist was the professional in contact with patients and remained present and active. And sometimes they would stay open on Sundays. And in the 13% who didn't go, 6% was because they had enough medicines, and 4% because others went on their behalf. So I'd like to pay tribute to the pharmacist. Now, the COVID crisis has taught us that of course, we knew how to work together on a bilateral basis with pharmacists, with doctors, etc. But here we've learned how to work in a multilateral way, involving all stakeholders. Let me use an example which might sound a bit like a caricature. Podologists overnight had to cease activity because they did not have any masks. So because they were not entitled to receive any masks. So thanks to a cooperation with the Order of Podologists and the Union of Podologists, first of all, they've been able to develop podologist centers, and number two, they could be part of the list of professions that could receive masks. And so they've managed to be included in the list so they could give advice on a remote platform. So this it has helped us to work on concrete subjects with all professionals. Thank you, Marie-Odile. I know that during the COVID crisis, your facility was the reference, and you said that that cooperation was prolonged after the epidemic, meaning that you're still working together. Could you please explain to us how does the public-private consultation is taking place? Because that was not the usual way of working. Mid-March, when we were hit by the first wave, if we put aside Mulhouse, here in Moselle, we were 24 or 48 hours ahead of time as far as the virus is concerned. The regional health agency asked me to pilot, to steer the coordination operations. It was resuscitation at the time, but now we have the lab. There was mass distribution as well. But at the time, we're talking about the resuscitation beds, intensive care unit. And there were two scopes, the north and the east of Moselle. And this is a trans-border area between Belgium and Germany. And it was on public and private structures. And the relationships are good, but there is competition. Things are not that simple. The national regulation today is such that because there is scarce medical resources in the east of France, let's say that, structures tend to steal doctors away from other structures. So I did accept, I was a bit worried, but I did accept to provide all my energy to commit myself to make a real coordination. And it was a big source of pride for myself. At the end of the crisis, when we started with summertime, we thought we could start the coordination, and private facilities came to see me. And they said, no, we don't want to stop because it went really well, so we would like you to continue. Please be nice enough to continue with our meetings. And I think that now, as far as the feedback is concerned, why did it work so well? I think because everybody was interested in this, but also because we had a very serious crisis. And at one point, between mid-March and April the 4th and the 5th, I think our patients' life was at risk. We almost went to war medicine, but it was very close. But we didn't get to that stage because we allocated all our resources. You know that I've been speaking in the media a lot. With all that community behind me, we knew that you were talking about hospital beds. We increased the number of our intensive care unit beds. We did it in view of a number of ventilators that was far from being enough, very insufficient in the private and in the public sector. And so we joined our forces together, and we tried to mobilize, to involve all players to support us. We were talking about masks. We went to retrieve the ventilators from the veterinarian clinics. It's important to say so today. It is incredible. I would have never thought before that I would be able to do that, but I did it with all the whole community behind me. And our strategy was to provide graduated response. Each night, we would need an additional 5 to 10 beds, so we would open them. And we knew that the hospital, the regional hospital center, at the peak time had 180 beds, and for the other ones, it was 100 beds. We went up to 220 beds. And originally, we had about 50 beds. So we have almost quadrupled our capacity. And I'm still surprised by the way we did it, because it did happen in a natural way, and the issue of coordination is very important. Communication as well, transparency to populations, transparency, and we did manage the masks the same way. We had to manage the curare molecules. We did it with common stocks. We put all the pharmacies with their common stocks, so none of our structure would have a shortage of product that could be deadly for patients. Sorry to interrupt you, Marie-Odile. Very concretely, what was said to us, in fact, what we did depart from the rules. We said, okay, administration is a good thing, but it is secondary as far as patients' interest is concerned and the urgency situation. So how did we do that? The objective was fairly simple. How could elderly people, chronic patients, they should not worry about the fact that they could continue to get their treatment. So even if the prescription was had expired, or for any kinds of drugs, in fact, the opium-based products, etc. We have renewed the prescriptions, and this has given a stability to the population, and the population has felt reassured. They thought the pharmacies open, and pharmacies will renew the treatment and will continue with supplying us with our medicines. Of course, it was necessary for the patient to be stable, and this has led to an exchange with doctors. And doctors would tell us, but do it, because I cannot do it myself. They were not well organized, because they could not take COVID patients in their practice, so, and they were overwhelmed. At the time, remember, people were told, please stay at home. So how do you manage to get some medicines if you have to stay at home and you are a chronic patient? So the pharmacist would take the order on the phone and would bring the medicines home to the patient. We would take lifts, we would open doors, so we had to take the precautionary measures. So at the end of the day, at the end of the evening, there were 4 to 5 people that we had to deliver. And it was very time-consuming, but was very efficient. But what was also very important is that we did investigate about what was happening with those chronic medicines. Was there an increase in the fact that it was not necessary to store so many of them, or underconsumption, showing that it was not an efficient organization? In fact, we were between -1 and +2. So it was just the normal situation. So the question that we might have today is, all those rules that we've been using to protect ourselves because the medicines were to be prescribed by the hospital, are they useful to protect patients? Are they efficient to protect patients? Or conversely, aren't they going to give rise to too much complexity? And let's not forget about nurses. We've exchanged a lot with nurses, you know, for the bandages, so people could continue their work.
As Dominique mentioned, so you did home delivery, and the physicians and really supported all these operations, home services, home deliveries, working with physicians, nurses. We had urinary tract infections where physicians would not come to patients' homes, but nurses were able to make decisions as to the next steps forward. And so in our experiment, all these recognized and valued. So those who, took part in that did this without any recognition. So we then managed to convince the Ministry of Health and funding services, as to when we go beyond the call of duty, prerogatives, rules, so we can fill the gaps and provided seamless treatment. And so we can be agile depending on the principle driven by reality. We can take measures accordingly. So Article 51, which has been debated and mentioned on many occasions, really mentions the, it's as though COVID-19 pandemic had completely shattered Article 51. That is really innovative, but two, it provides a framework that is too stringent, not flexible. How can we use Article 51 better and more often? So Article 51 is a formidable step forward for France, but we, in terms of our neighboring countries, which I know well, between the state, the national health care, and the medical social community medicine, so our government is scattered. Our governance structure is scattered. Of too many organizations with the high health authorities, we have 14 levels. And Article 51 is about allowing to provide flexibilities between hospital management and actual needs. So this is fantastic. This is what can be seen across the 3 Nordic countries we work with. And insofar as we're concerned, we work on a project to open up primary care centers in France based on kind of so-called Nordic models, paid on beyond being paid on medical acts or procedures. So this is a step forward. So Article 1 is a fantastic tool, but we need to go beyond that. We need to go further, because the healthcare cover system hinders and does not encourage its coordination needs. And everybody believes in that in France as it is. And I think Article 51 allows to put in place a framework and to put appropriate measures beyond the set framework. So we can see that on our local territories, we have primary care units where we can create things that are faster, that are more agile, flexible, and notably in terms of organization, but in terms of compensation. So our system is not adapted as per the rising needs of patients. So how can we make sure that everybody can change their business model, which is not a simple thing to do, to meet new and developing health needs, chronic patients, for instance, the best way to get organized. We're talking about all of this, and these are all strategic needs. As you said in your preamble, you need to trust people in the field, because at the end of the day, who can benefit all these organizations? The patient can, especially because the patient is fragile. The patient has at times is facing with complex health pathologies, and we need to be fast as well. And if we want to have a structure, an approach that is too structured, too administrative, This will put down healthcare professionals, and they have this goodwill. He wanted to jump in. Yes, I believe that I'm the one who drives. I think what has been said is really important. What's happening in the community, health services. And it brings together public and private and healthcare professional. That goes beyond the regulatory framework. We feel that we do know where we should be heading, where we want to go. And we put in a lot of hope in this latest consultation round, in this latest think tank referred to as the healthcare secure. We must work on our statutory issues. We must address these. The current system is old-fashioned and is irrelevant. We need to go beyond that. When it comes to criteria of funding of healthcare units and setting a value to services, we have high expectations as to remuneration of healthcare professionals as well as remuneration of the activity. Ségur has redistributed money, but funding, but this we haven't used what could be a lever in terms of bouncing back, in terms of turning what we've done into life. And we've shown the incredible positive effects. We had good hope on the footsteps of this crisis and to be taken into account by the national level. But the national level is not seizing the opportunity, it's not embracing the opportunity, not the way we would want it to. As Pascal mentioned, Article 51 invites to go beyond the set limit, but this really is, I mean, the current nomenclatura or classification is obsolete. We should be paid on the basis of the time spent for the patient, not on the medical act. And the patient is there to be secured. In experience, thanks to Article 51, this is what we do. And then we need to work together with pharmacists, nurses, and we can run the therapeutic educations, because who's going to be benefiting from all that? The patient. So we need to work on that. There's another Article 51 that puts together biologists, physicians, nurses, where we can get results faster as protocol of understanding between the physician and the biologist. And, well, if I don't give my agreement, you can't modify. No, thanks to Article 51, we are making smoother the system for the benefit of the patient. Now, Article 51 can be the worst and the best, as has been reported. Tell us a bit more about Article 51. We can't hear you. I had muted my mic. So the point, the idea, the starting idea is good, but regulations is that we're very far. There's still a long way to go insofar as if we look at, the way things have been applied in France, they've been applied in within a very limited scope. So we have 3 regional coverage plus 13 regional coverage, 3 national coverage, and 4 areas of a population of 4.5 million people. And this is a multidisciplinary approach. So 1 on the insulin pump, installation in an external center as opposed to a hospital centers in Lyon. 1 which is about catching up on the ETAP program involving remote surveillance services. And this is one of the remote surveillance programs that is one of the most successful ones. And the third one is an attempt to put in place to install insulin pumps. This has not been given a go-ahead, but one that's been given a go-ahead is multidisciplinary approach in the MSP in the northern part of France. There was also one on liberal or community or private practices and being able or being given the authorization to install insulin pumps, so beyond the set regulations. So, in terms of the healthcare journey, and Article 51, once again, is an experiment. It will last, we don't know how long. And these might result in new ways of compensating physicians. So this is part of Article 51. We did have a discussion on the task force on the evolution of modes of compensations. And now the task force has been put to sleep. Well, there's been COVID in between the start of the work and now. And as previous players did mention, this is where the action is. This is where the focus has to be. But the hospital practitioners has to work in a community, private, irrespective of the status. They shouldn't be hindered for these interdisciplinary exchanges. So what is going on right now is that there are fewer and fewer private practitioners. And I'd like to submit a question that's been sent online. So could we imagine a kind of a single exercise contract for a private structure like an elderly people's home, and so that private practitioners can work better together? And I don't think this is the right approach to the problem. The problem is not about a single status. The problem is about capacity in the various modes of status. There has to be compatibility there, because people might be losing their benefits. If you're public service and you want to go in, if you're in a public service, you want to go private, you might be losing retirement points or pension points. So the problem is to make feasible this multifaceted exercise, and so that people who want to go from private to public or vice versa have bridges to do so without getting penalized. So elderly homes have been deeply impacted during the COVID-19 crisis. And we can see that physicians find it more and more difficult to free up time to provide support services to elderly patients. And even if we find it difficult to find physicians, even for emergency services in elderly folks' home. And so elderly people with a number of pathologies, status is not relevant. We have people who are employees of elderly folks' homes. So who's going to be watching the patients? What's going to be how the protocol is going to be managed? And so sometimes status is a stumbling block. And this is about what is the needs, what is the care offering over a given local territory, and how can we best meet patients' needs. So we need to not forget about what is essential. When we talk to physicians, says, I'm really fed up with administrative burden, I'm really fed up with red tape. And they're right. And said, well, we're going to have a local community of healthcare professionals and care centers offering a wide array of caring fields of specialization, and they need to set up such a structure as like, okay, let us alone with these less red tape, more operationals. We need to meet the needs of patients. We don't need to create structures. We need to work together to move towards recognitions of working together and be really efficient. And the GP in France, could we do away with the GP? Or in France, could we find other solutions? Because this link might come to become a stumbling block in the care journey of patients. So maybe not, put the GP at the center or as the first link in the patient's journey. Maybe that's the French specificity. Now, there is the, in France we have the GP. This is a gateway, but in many countries, neighboring countries, your GP is appointed by the state, and based on your local place of residence, you must report to the GP. Otherwise, you don't get reimbursed. Here in France, we have the freedom of choice to consult the physician we want, and there's portability as well. But the prerequisite is for us to have a GP. Millions of French people don't have any GPs, and the fact of having to go through GP is, to come back to one of the fundamentals here, is a shared medical file. Despite recent effort, only 8 million French people have a shared medical file. We often criticize the Brits with the NHS, but 65 million Brits have 65 million shared medical files. That's a continuity of healthcare. As long as we haven't resolved this issue of shared files and simplified governance, you might be of good will, but you might not be able to change the way things are. 2 years ago, studies showed that private and public hospitals receive 2 to 2.2 new standards a day. And for a hospital, this is a standard we know we have to apply it. But we have recommendations in many learned societies. What do you do with this? You apply this, and this is opening up to a legal debate here. What we want out there is to forget all that, so to speak, and to really move to be more operational. We don't want rigidity as induced by the system. Our system does induce this rigidity. And for GPs, all patients want to like to see, to consult with their GP when they want to. And in our COVID centers, and those you had the local GPs would receive their patients without any GPs, so that they could see someone, they could consult a physician. And sometimes in some of the populations, they don't want to go via GPs, and maybe there's a rotation system, so people always, you might end up not having just a one GP, but maybe a GP that will meet patients' needs, even if you don't have a dedicated GP. And regional health agencies, ARS, and this is the key issue here around this table. How can we make sure that these are not a hindrance, but how can this drive to better working better together today? Because so far the model is very depending on the regional health authorities or agencies. How can we make sure that things work more smoothly and more efficiently? Maybe 2 or 3 comments as to the status. I think I've way more interested in looking at ways of remunerating healthcare professionals. Statuses have become a hindrance, a stumbling block. And if we really want to move forward, we need to pay people on a par with what they deserve. And as a reflection to what they deserve, the GP issue is essential, is a key issue. But I'd like to agree with what Mr. Ramsay said. I feel I'm completely in line with what has been said. So I'm coming to the regional health agency issue. And a few years ago, we had kind of mission-driven administrations, and we've moved to regional health agencies, and they're a bit of a mixed bag of things that people put in sort of miscellaneous functions, from health to social and eco-social services, and whoever embraces too much does very little at the end of the day. So what? So these agencies again have been transferred to clusters. So let's say the territorial scope within regions. And then you're perfectly right to say that it is way more depending on the team in place as opposed to what they do in terms of possibilities they have available, as opposed to being fully kind of regulatory driven. But indeed, with the depending on the team of regional authorities we work with, results can differ widely. And large countries, and I think I'd like to recall that this is public money from the national health system. So we have organizations based on salaries. So we almost always, I mean, we do need regulating authorities, but regulating might not be set up the way it should be, or does not meet at this point in time what we can do on the basis of the post-COVID feedback of experience. Very briefly, Gilles, I'd like to go against what has been said. I defended, I advocated in favor of regional health agencies. Imagine the structure receiving almost every hour orders, counter orders to apply over their territories. They ended up in having the same difficulties as other players, carers, insurance, and others. So lots of goodwill there. People try to do their best, but this is very heavy and cumbersome regulations. Then we need to take stock of all of this, and we need to coordinate really with medical insurance. It's very frustrating. We could have talked about this, all of these at length. Very short, very brief answers I'm inviting now. And final point here, what I heard is that France has been unanimously and loaded for its responsiveness capacities during the crisis. If there was one thing, only one thing, you could get your inspiration as a result of COVID-19 crisis that France can do, what would this be? Agility. We shifted from 5,000 to 10,000 intensive care units, from 5,000 to 10,000 beds in intensive units beyond the masks. Issue the agility to really accommodate this, to respond to this tsunami, has been hailed abroad. And across the territory, this is about working together. This has been about working together. We need to continue working together. We need to get to know each other. We need to train together. We need to have multi-professional training curriculum so as to facilitate and to oil the whole system. Agility and the skills of all of those who cared for patients and those who delivered care, and I was very much impressed to see the reaction of the responsiveness of hospitals. Turning bed is really always complicated, and people took many risks transferring patients by helicopters, trains from one region to another. I think it was a very positive reflection as to the capacity of responsiveness of the healthcare system. Marie-Odile. Fully agree on the regional health agencies. They've been really finding themselves in an extremely challenging situation. And I think we are capable, we're capable to get there. We need to take stock of all these in terms of the capacities and the feedback based on experience. What about you? Microphone, please. Your microphone, Jean-François. We can't hear you. Can we do with the GP? No. We need a team with a physician available, and these have to be relieved from red tape. So apologies. No, that's it. You have 10 seconds. On regional health agencies, they really need to be closer to the local level. And finally, as to what was good about this first part of the crisis, there has been the tremendous solidarity as the key quality of our country. Thank you. Enjoy your lunch break. We'll meet up again at 2:30. Solidarity in response to disability, with our Secretary of State in charge of disabled people. Philippe Normandy will be the interviewer. I'll speak to you again very soon indeed. Enjoy the day. Thank you.